All right, welcome everyone. Let's get started for today. So today's seminar is being live streamed on social media. So for those of you who can't make it directly to the Zoom meeting, welcome on our social media platforms. Sarah, are you there and ready to get started?
Yep.
Okay, perfect.
Yeah.
So welcome everyone today. My name is Jesse Ehrlich. I'm the program officer in biomedical engineering at McGill and program manager for the MedTech Talent Accelerator. For those of you who are not aware, the MedTech Talent Accelerator is a national training program designed to launch the next generation of industry-ready talent for the Canadian medical technology sector. The program is a collaboration between Toronto Metropolitan University, McGill, Dalhousie, University of Calgary, Biomedical Zone, and MedTech Canada and its member companies. So for today's Explore MedTech Innovation Seminar, we're very happy to have our speaker today, Sarah Seams, who is an advanced practice nurse educator and medical affairs clinical specialist and trainer at BD Canada. And Sarah will present a talk entitled MedTech Translation into Practice, End User and Clinician Impact. And before we get started, I'd just like to do a land acknowledgement. So McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples, including the Haudenosaunee and Anishinaabe nations. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which peoples of the world now gather. Okay, and without further ado, Sarah, please take it away.
Great. Thank you so much. I did just type my name in the chat. If anybody's looking to find me I'm on LinkedIn. My last name is Smees, S-M-E-E-S. Just you'll have a better time trying to find me with that last name. All right, so I'm going to just share my screen and we'll get going. Thanks everyone for attending today. I appreciate your time. So I'm going to go through some slides that will have an intro to myself as well and why I'm here talking to you today. So let's get started. So just overall, because I do work for BD, medical device manufacturer, MedTech company, any products that I use in this presentation are related to vascular access specifically. If there's any discussion about products, it will be all on-label use, and just to guide you to the instructions for use if you're looking to use any of these products yourselves. So today we're going to go through just explore an understanding of opportunities in MedTech through the eyes of myself, practicing clinician working in the industry. So I am a registered nurse, and I've been in the MedTech industry for going on 8 years now, but have about a 15 to 20 year of bedside nursing experience. So we're going to go through a few pieces of technology that have informed my practice, specifically that were created by BD. So we're going to go through some of the science and technology around PICC insertion, that practice specifically, and we'll go through what all that is and what that entails. We're going to go through how clinicians support improved outcomes as being front and foremost on the front lines of care. We have a really great opportunity to see what's happening in healthcare and to be able to have an input in optimization as far as an efficient system goes, and in a meaningful way to the patient as well. And we're going to go through a few ways that we could potentially link engineers with end users. And that could be a nurse, for example, or even the patient. So looking at that patient experience. So just a little background about Becton Dickinson, or BD. And I do work for BD Canada. So for many years, the slogan of BD is advancing the world of health. So by developing technologies, services, and solutions as well, we're really helping to be the forefront leader in healthcare innovation, and in countries all over the world. So not just North America, but we're also overseas. So just a little video to highlight some of what we do.
Focused on an outcome, a result, a goal. You move healthcare forward, but with changing needs, it helps to know who's on your side to discover, diagnose, and deliver. We are BD. We're made for what's next in health, turning what if into what is for the last 125 years, wherever care is needed and delivered. Because the future is more promising when we work together to make tomorrow better. BD, advancing the world of health.
All right. So where is BD found? We are across all sorts of healthcare settings. So we're in hospital, could be in surgical suites doing very invasive interventions, could also be in the diagnostic lab, research lab. We're looking at analytics and capturing data, presenting data in a meaningful way as well to the hospital systems themselves and end users, as well as the pharmacy. We have a lot of technology in the pharmacy spaces. The other really quickly growing space is an alternate care setting. So moving care perhaps out of that acute care setting and into more of a community or clinic setting. So BD's moving in that direction, as are a lot of med tech companies, but that's something that you'll see with all sorts of technologies, with wearables and different ways to track and care for folks at home or wherever they call home. So the division that I specifically work within is called Medication Delivery Solutions, or MDS for short. So this is just a snapshot of some of the aspects that I'm responsible for, looking primarily at vascular access. So any sort of touch that a needle may have with a vein for purposes of blood draw, for initiating vascular access. So just a regular peripheral IV, if you or a loved one were to go into the emergency room, for example, maybe get some hydration or medication, or all the way up to and including more of an advanced complex line called a peripherally inserted central catheter, or PIC. So this is a skill that I developed several years ago to actually insert myself. And I'm going to walk you through the technology of that just to have you understand how important this medtech industry is in changing efficiencies and flow in healthcare for the end user and the patient, and making care more accessible in a more timely manner. So that's what I'm going to focus on just for a few minutes, is that peripherally inserted central catheter, or really just honing in on this vascular access piece. So this is kind of what I do in a day. So I teach and train clinicians, could be physicians, nurses, radiology technologists, ultrasonographers, how to use ultrasound guidance to access patients' veins. And then going a step further, we have magnetic tip tracking technology and ECG technology to be able to insert and confirm the exact placement of a peripherally inserted central catheter on a patient. So this is something that traditionally has been done in the interventional radiology suite in a hospital, but is able to be done right at the bedside, and in some situations in a clinic setting, or even at the home. So again, really changing that flow and how we deliver care. I am a speaker for the Canadian Vascular Access Association with my BD hat on to speak about best practices based on evidence-informed research. I work very closely with a territory manager, or some may know her as a sales rep, but she helps to support that aspect of my role. And then I provide the teaching and education and training for the end user on the products that hospitals are looking to bring in or move to. So think back to something like a stethoscope. Before a stethoscope was invented, we used to have to put our ear up to a patient's chest to listen for breath sounds, for lung sounds, anything abnormal, which could be kind of a crackling sound or something that might indicate infection. The stethoscope was invented and now is used routinely. We wouldn't think about holding our ear up to somebody's chest. We use that. In fact, it's so easy that a child can do it and can play and can hear a heartbeat of maybe their own heartbeat or somebody else's heartbeat. So that's maybe a simple innovation that we probably take for granted now that we have the stethoscope. But what about intravenous vascular access? So again, that bread and butter. So if you or somebody you know have had experience with this, I look to how many times you've maybe been attempted at an IV start or a blood draw or someone that you know. So perhaps somebody going in to have a baby, for example, they need to start IV fluids on. Did they have a hard time doing that? How many pokes are too many? So when did it become acceptable to poke somebody 2 times, 4 times, 6 times, and have another nurse come in and try? So what can we do from a technology standpoint to improve this practice? So ultrasound technology is what the answer to this is. So we really are able to improve first stick success by using real-time ultrasound to be able to get that needle right into the vein for the purposes of vascular access. So here's a little video of what that looks like. There's no volume to this, so I'll just walk you through it. So we've got the ultrasound on the arm. You're going to see the image that would show up to the clinician on the ultrasound machine. The round circle is the vein. And we're going to see in real time the tip of that needle come down from the top of the screen. It looks like a bright, shiny white star that's going to penetrate through the vein wall and drop down into the middle of that vein. So there's no guessing, there's no question. We know where we are. We would have a great blood return in a patient. We know we're in the vein, just making sure we're right in the middle. And then what we are able to do is even walk that needle in a wee bit more before we thread off that plastic catheter into the vein. So this is a nice seamless way that clinicians can get in the middle of that vein. So something else to consider when we're looking at catheter longevity. So how long an IV stays and works in a vein is looking at the size of the catheter compared to the size of the vein that we're putting it in. So here's a video that shows on the top, we've got a smaller catheter, on the bottom, a larger catheter. So you can see the hemodilution around that smaller catheter. We have a whole lot more. So this catheter on the top is actually going to last longer because we have greater hemodilution. So we're able to use ultrasound to actually measure how much space the catheter takes up in the vein. And there's been literature to support we want less than 45% of the catheter taking up that space in the vein to have optimal outcomes. With folks who have cancer or some sort of hypercoagulopathy, we are looking for something less than 33%. So again, using technology to be able to quantify this and align with best practice and what's been researched to have the best outcomes possible. We've developed a system that allows clinicians to do this very easily, that actually spits that percentage out so that we can make a decision on what is the most appropriate gauge or French size of catheter to use. So looking at one of our products, for example, the engineers at BD have worked to create a catheter that has a smaller outer diameter, but we still have a nice large inner diameter because we need that large inner diameter for high flow rates, for doing things like CT power injection through a catheter. So this is really wonderful alignment with engineering, as well as our research that shows us that we need that smaller catheter in that bigger vein. So not only do we have clinicians working with the end user, the patient, to choose a large vein, we've got engineers who are creating products that decrease that outer diameter to align with best practice. So looking at PICC insertion, I'm going to just do a little bit of an intro of what this is. So a PICC is a peripherally inserted central catheter. It's essentially a small tube that's inserted into the veins of the upper arm, could be either left or right. And the catheter itself could be up to 55 centimeters long, and it's going to travel through the vein into the largest vein in the body, which is just above the heart. It's called the superior vena cava. So I talked about hemodilution earlier. Think about this tip location. When we look at how many mils per minute of blood flow in the arm versus the superior vena cava, we're looking at something that using an analogy, I talk about Niagara Falls. So think if we have any medication flowing into this massive amount of blood flow, it doesn't have time to fester and cause problems with that vein wall like it might in the hand or the lower arm or even the upper arm. So the tip termination is what makes it a central location. So this traditionally has been done, as I mentioned, in interventional radiology. So it's taking up time there. It might be a radiologist who does that. Although we know that a nurse could do that or a radiology technologist could do that. We also have the safety issue with the traditional way of inserting a PICC, and that goes back to radiation exposure. So they have to, in real time, expose the patient to radiation through something called fluoroscopy in real time. So we're seeing that real-time imaging happening or a real-time X-ray happening. So that's that radiation exposure that we can prevent if we do it a different way. We're also looking at human resources. And in healthcare right now, that's a very big problem. Actually, I would probably call it a crisis these days with regards to who we have available in these suites in interventional radiology to be able to do these procedures. So if we can find a way, and again, with this MedTech piece, we're really trying to find a way to improve efficiencies as well as ensure we have optimal outcomes too. So looking at this is kind of the typical flow at what happens when we have IR using fluoroscopy to place a PICC. So many steps requiring a lot of time, a lot of patient transport. And during the pandemic, this was a huge challenge because in the hospital, we didn't want to be transferring patients from different areas of the hospital. So we have a solution whereby we get the order for a PICC. Somebody is able to go with the technology to the bedside and place the catheter right at the bedside. We have the technology to approve the location of that tip and then immediately release for treatment. So a lot quicker of a process, fewer steps, and actually looking at patient satisfaction. It's a nice option for them to be able to stay in their beds or in a clinic or home environment, depending on where they are. So looking at the technology specifically, you're going to see on some of these images the word Bard. If any of you are familiar with Bard as a MedTech company, that's the company that I started out working for, and BD purchased Bard a few years ago now. So we're in that phase of transitioning from some of the Bard logos over to BD. So that's why you see some of these Bard logos on the screen. So we do have the only 3-in-1 system on the market, whereby we have an ultrasound machine. We have a magnetic tip tracking sensor that's placed on the patient's chest during the procedure. So as the catheter is advanced into that arm and thread through the chest area in that vein, we're going to see in real time exactly where that catheter is because we have a magnetic tip technology on the end of a stylet in the PICC. Then as we get closer to our point of destination, or I mentioned the superior vena cava, we're going to use ECG to confirm. So we do a comparison with our P wave, and I'll take you into this a little bit more for greater clarity. So looking at cardiac physiology, this is the heart. It has a natural pacemaker to it if it's working properly. It's called the SA node. And this is a small group of specialized cells just located in the upper right atrium. So what we see on an ECG rhythm, when the SA node fires, we see that as a P wave. So that's this little P wave before that greater spike that is the QRS. So it's this knowledge and understanding of cardiac physiology that helps inform the technology that we use to confirm PIC placement. So this is an image of the PIC itself that comes in the tray, and there's a metal stylet that is preloaded through the catheter. And at the very tip of the catheter, there's a tiny magnets, as well as that ECG technology. So working in conjunction with the portable system, I'll take you through how it works. So as the PIC is advanced, we see an increase in that P wave as the catheter approaches the cavoatrial junction, or right where the SVC meets the atrium. As we advance the catheter further, we're going to get an even higher P wave spike. If we go too far, so we've gone into the atrium, we're going to see a small deflection before that P wave shoots up. So we've gone a bit too far, and this isn't where we want to leave our PIC. So we would actually pull it back to the number 2 and leave it there. If by chance the clinician isn't paying attention and we go way too far and even further, we're going to have a biphasic appearance in that P wave. So number 3, we would pull back 1 centimeter and we would leave that catheter with our highest P wave without a deflection. And that's where we want our PIC placement to be. So a couple of warnings about this. We definitely need an elevated, consistent, present P wave. So if somebody has a pacemaker that's actively firing, we would still get a chest X-ray or use fluoroscopy to confirm. The same can be said if they don't have a naturally firing P wave, such as the case with somebody who has atrial fibrillation. But we can always get that chest X-ray or use fluoro to confirm. I'm going to show you a short video of the initial area here of the PIC insertion.
Begin by preparing the supplies on the sterile field. Positioning components in order of use will provide easy access and reduce disruption in the procedure. Apply a layer of sterile gel to the covered acoustic window of the ultrasound probe. Then, using the ultrasound, locate the target vessel as well as an adjacent artery and nerve. Center the dot markers on the target vessel. Next, administer local anesthetic at the intended venipuncture site. You can visualize the infiltration of the lidocaine into the tissue on the ultrasound screen to direct the anesthetic to the desired location. Reposition the probe cover to remove any wrinkles. Then, center the dot markers on the target vessel and keep the dot markers centered. Slowly advance the needle while looking at the ultrasound screen. When the needle approaches the target vessel, you should see the anterior wall indenting. Once a venipuncture occurs, the vessel returns to its normal shape. Observe venous blood return. Remove the guide wire tip protector from the guide wire hoop and insert the flexible end of the guide wire into the introducer needle or catheter and into the vein. Advance the guide wire to the desired depth. In this case, we are placing the PIC at the bedside, so we should not advance the guide wire past the axilla. Gently withdraw and remove the introducer needle or catheter while holding the guide wire in position. Loosen the tourniquet while holding wire with right hand. Cleanse skin of ultrasound gel and, if necessary, perform small skin incision or dermatotomy adjacent to the guide wire to facilitate insertion of the dilator and sheath. Safety scalpel, and return to sterile procedure field. Advance the dilator and introducer sheath together as a unit over the guide wire. Using a slight rotational motion, holding low on the dilator. Remove the guide wire and dilator from the dilator and introducer sheath. Withdraw guide wire, leaving sheath in place. Upon removal, blood may start to come out of the dilator sheath introducer. Finally, place the dead end cap on the introducer to occlude blood flow.
Okay, so the next step, and I'm not going to show you the video just for the sake of time. The next step through that dilator, you would remove the inner cannula and insert that PICC. So it's that long skinny tube. It was kind of a purple color you saw before. So when we do that, then this is what we see on our screen. So if you can follow along with me, we see on the top of the screen, it looks like a yellow lollipop. That's the tip of our PICC dropping down into the SVC. Down below, as that lollipop gets closer to our point of destination, you'll see that P wave elevating higher and higher. We have a green diamond. That's the computer telling us it thinks that we're where we should be or pretty close. We're looking for any deflection in that P wave. So you'll see it here on the screen. So we've gone a wee bit far. So we would pull that PICC back and we wouldn't have kept advancing. So that's all happening in real time. And this is why we do not need a chest X-ray or the use of fluoroscopy to confirm placement. So once we have our highest P wave with no deflection, that's where we leave our catheter. So pretty neat technology overall. This is supported in the evidence. I've populated our Canadian source, although it's definitely globally the gold standard using ECG for PICC tip confirmation. But our Canadian Vascular Access Association does make mention of that, as well as the use of the tip tracking technology to see where the PICC is going in real time. And then if by chance we don't have that, we could use fluoroscopy. However, we want to limit the use of that due to the radiation exposure, both to the patient and to the clinician as well doing the procedure. We do know that ionizing radiation is a leading source of dangerous radiation exposure for medical personnel. So in Canada, we have multiple hospitals using the technology. Mount Sinai published a paper talking about their experience. They have radiology technologists inserting at the bedside. And overall, the elimination of patient transport to IR, they spoke about their improved efficiencies as well as time and flow of patient transport, reducing chest X-rays, therefore decreasing radiation exposure, and reducing the wait time for PICC insertion. So we've got patients who are waiting in hospital to have a PICC placed just because there's backups of other procedures in the IR suite. So if this is something, again, we can take right to the bedside, we're improving care. They also looked at cost savings in their paper. So I'm going to switch gears a bit. I wanted to just do an introduction to technology that is being used currently by myself. I'm deeply involved in that PICC aspect piece, but nurse innovators as a whole are a group of people I hope that you will find close relationships with, either as students, engineering students, or when you get further on into your careers, to really collaborate with nurses who are, in a lot of instances, your connection between the patient or other end users of the technology. So just a couple of other examples that are very basic, but very, very useful. So these folks in the States created this little flashlight that clips onto the nurse's scrub top and allows them to go into the patient's room at night and not disturb their sleep, but allows them to be able to see what they're doing at the bedside instead of flipping on the light and walking in. They link this back to the patient's inability to actually rest during a hospital stay, and patient satisfaction scores. And that's a huge indicator in the United States. So the other piece with the light, it's called Unite Light. It's got a red, blue, and white hue, different options to it. And one of these actually the nurses will turn on, and it was created to help keep nurses working night shift alert and awake. So that's something else to consider in addition to the patient care aspect. Another piece that was a little bit more associated with IV therapy and vascular access was, again, looking at during the pandemic, having pumps outside of the room and how to get the tubing elevated off the floor so that it wasn't dragging. So just something simple like this. A nurse engineered this thing called Highline that helps keep these catheters up off the floor. And then other nurses were using securement devices for catheters to stick on the outside of the door to help keep these lines up off once they were outside of the doorway and to the pump, so that they didn't have to enter in and use PPE every time a pump was beeping. This is a great idea. I mean, there's also challenges with patient care and keeping an eye on the IV site and seeing what might be the problem. But if it's just something like a kinked tube that once the patient moves off that kink, they can quickly remedy that from outside of the room. Looking at AI and looking at another option. So a gentleman down in Australia has this slogan: we haven't reinvented the wheel, simply how fast it can roll and if we can steer it better. So looking at education and nursing, Bradley Chesham has been working on using virtual reality to teach nurses and other healthcare professionals. So his intent is to be able to deliver this education throughout the world, and somebody doesn't physically have to be in a building. And we've seen a lot of that transition through the pandemic as well with education. So Bundle of Rays is something you could check out as another new innovative technique. So nurses overall really understand how products and practices work as the end user. We're always thinking of workarounds and making workarounds during practice if the products don't necessarily work exactly how we would like them to as well. So we can recognize when these practices and products don't work. We know that humans are complex, and it can't necessarily be a one size fits all with MedTech. In a perfect world, an anatomy textbook would inform our understanding of the human body, but the human body throws all sorts of wrenches into that, and it's not always the way we think it should be. Nurses understand how to build relationships, so could work closely with engineers as well as the patient to understand their needs. Work well under pressure may be the strongest link between the patient and the engineer looking to design something new or create a new system or new way. Nurses are natural problem solvers and critical thinkers. So again, working bedside and having 12 hours of, we describe it often as putting out fires and having to critically think very quickly of what we could do to either improve care or save somebody's life. So it's very, nurses are a very important piece of that end user experience. So I'm sure as an engineer, you will have heard of hackathons. In fact, they were initially pioneered by engineering, but there's been an increase in nurse hackathons. So looking at innovation methodology, we do know nurses are engaged in one-off problem solving. So really quickly working on their feet to MacGyver things at the bedside. But the problem with this, we lose a lot of important experience from nurses, and we're losing a lot of that from the workforce right now. So it's something that we want nurses to be able to be collaborative with people creating and engineering devices, because we don't want to lose what we know is so valuable with regards to that. Nurses may not see themselves as innovators. This isn't something that's widely broadcast in nursing schools, that nurses can be innovators and can work with engineering to help improve care. But looking back, so there was a Nurse Hack for Health held in May 2021. This collaborated people from all over the globe. And it was very eye-opening for the profession as nursing, as well as other folks who were involved in the hackathon to support nurses to really use their ability to create and collaborate and try to problem solve through existing health challenges. So nurses are and can be seen as the subject matter experts, and especially if they're honed in on a specific creation or practice. So look to somebody who might be involved in something that you're looking at creating as an engineer. We focus on the human-centered design approach, looking collaboratively to solve problems with the end user, which really ultimately is the patient's needs in mind. Just to kind of throw out another idea here. So the MIT hackathon have resulted in the creation of 50 companies, and over 240 million has been raised. So nurse hackathons are popping up all over now with schools. Primarily I've seen in the States, but there's been some action here in Canada as well, because we're bringing together patients, nurses, doctors, engineers, developers, business associates, those from the insurance field as well, and policy experts to really help to create our healthcare ecosystem. So this is one nurse innovator. I'm going to play this real quick so we have some time for Q&A at the end. But Rebecca Love is very active speaking about nurse innovation and looking at the future of healthcare.
Today, there are nearly 19 million nurses worldwide and 4 million in the United States, making up roughly half of the US healthcare workforce. Every day, nurses stand on the front line between life and death of patients, handling hundreds of thousands of dollars of highly complex medical equipment, technology, and medications to keep a patient alive the many hours a day a physician is not by the bedside. Every clinical interaction begins with and ends with the nurse, and nurses are the end user of nearly every medical product on the market. However, nurses are rarely, if ever, engaged in the decision-making process of which products are to be brought forth into the healthcare system. I can't tell you the number of times as a nurse, new products were rolled out that were supposed to decrease our workload, but actually made more work for us. Let me give you an example, something like this stethoscope. Only kidding, they really didn't give us that stethoscope. But many of the devices that they rolled out had a similar impact onto our workflow. Let me give you an example. When I was a floor nurse, our hospital decided to roll out this new device to help us with communication. So we took this device, put it around our neck, and off onto the floor we went. Suddenly, this device started screaming at us. Dr. Smith is on the phone. Your blood products are ready. The IV is beeping in room 16. Your new admission is here. By the end of the first week, we'd all taken this device off and put it at the front desk, explaining to our manager that had not at all helped our workflow, but significantly complicated it. Eventually, the hospital brought back out this company to work with us on the design of the product. But from that moment forward, I wondered, what if they had engaged with the nurse at the beginning of the design process? How this would have driven down healthcare costs and increased productivity. Because the truth is, nurses are natural innovators, and they know where all the inefficiencies are in healthcare. Research studies show that nurses do 27 workarounds per shift and are in 36 different places over the course of an hour. That means nurses are innovating in a highly inefficient healthcare environment, 27 times a shift. They're MacGyvering the medical devices and the products on the hospital floor to better serve the needs of their patients. The challenge is, workarounds are not considered a good thing in nursing. They're not recognized as innovation. They're seen as skipping over policy and procedure. Unlike places like Google or Amazon, where employees are rewarded for identifying inefficiencies and fixing them, nurses run the risk of losing their jobs.
There, I'm just going to stop it there. It does go on. If you want, you can find that open access online. It's a TED Talk she did, but really important to highlight the collaboration between nurses and engineers in the beginning stages, so we don't get to having to do all of the MacGyvers while we're working. So looking at you as a group of engineers from a clinician standpoint, seeing how much you're very needed right now in the healthcare field. So looking at electronic medical records, how can we improve this system? Looking at VR for education and practice, looking at AI as well, looking at data mining in MedTech, but really meaningful data mining. We have all of this data, but what is meaningful, and how can we make change in our system for the better based on that data collection? An uptick definitely in smart devices that are or wearables, so that we're looking at care in non-acute settings, perhaps in the alternate care environment, and just medical devices as a whole. If somebody can figure out how to make an invisible pick, that would be just wonderful. Looking at communication, improved systems thinking, you have a mindset to help design things in a complex system. So looking at healthcare environments that are changing, looking at data and healthcare in a different way than the people who are working within it. Is spending time with the end user and patient. So you're needed in this space as well to really understand what the needs are, to solve a problem that someone cares about. And it could be yourself, it could be a loved one. And then again, meaningful data collection. So developing clinician relationships. You could collaborate with somebody working in a medical device or MedTech company. There are also nurses in formal educational programs, much like the ones within the group. So you're looking at design and innovation in the early stages and people with fresh eyes and new ideas. There are specific programs with healthcare innovation, that are certificate programs as well. Developing clinician relationships. So nurses and nursing students are eager to create change and comfortable with technology. Look for clinicians and healthcare providers working on the front line. There are lots of people who may have found a better way in doing things. So looking at those people who are energized and want to be able to make things better. Subject matter experts, depending on what you're looking at creating and developing, and family and friends, people who have had experiences within the healthcare system. So wherever you can and locate people, maybe social media, online forums, as I mentioned, nurse entrepreneurs, and just overall effective change managers. So people who are looking to make things better and who are not okay with status quo. So developing patient relationships, you might be looking to family and friends, your community, neighbors, friends, social media. You might be looking at post-care surveys. Of course, this would have to be in compliance with legal and privacy laws. Job shadowing to hear feedback in real time if you're able to do that. And then collaborating with medical device company. Somebody like myself, I'm working directly with people I'm teaching with patients as well. So I have that relationship and collaboration. So what's needed next? Something different than the way we've always done it. If the way we've always done it is not okay. We want to challenge the status quo. Think of what will healthcare look like in the years to come. What you can envision. How can you make that better? And what role will MedTech play in this space? What role will you play? Hopefully you'll be involved in MedTech because this is a platform that you can very much help to make change for what's next in healthcare. So that's it for my presentation. I think we do have a few minutes left. If anybody has questions, I'm going to stop sharing and see if there's anything in the chat. I think we're good. Anybody questions? Come on off mute.
All right, everyone, we're welcoming questions at this point. Thank you, Sarah, so much for such an excellent presentation.
You're welcome.
Jeff, please.
Hi, Sarah. That was fantastic. I'm a professor at Dalhousie and spun out a company myself, which is now in Montreal in the respiratory field. I'm wondering, I have a bunch of questions, but I'll start with one on the more beginning part of your talk, which was on the medical devices you're involved with the company, like the PIC catheter and those sorts of things. You showed one slide where you made the process of treating a patient much more efficient, less steps in the pathway. And I'm wondering how that affects issues like reimbursement, for example. If you're knocking people out that are no longer necessary for the process, clinicians might have some reticence to transition to that because they can't bill for some parts of the process. This might be a fallacy that might not be true, but maybe you can share your experience if you know anything about how the healthcare system responds to improved efficiencies where they can no longer bill.
Yeah, I hear you loud and clear. And it's something that as somebody working within the medtech industry, we have to stay distant from that because we aren't making decisions on funding and reimbursement for hospitals. But I can tell you, again, going back to workarounds. So, for example, a lot of PIC programs I've helped develop have still been within radiology, maybe nurse or radiology technologists inserting the line. And you may know in that space, there are procedures that maybe a radiologist isn't exactly the one doing the exact procedure. They may have a little bit of a part in it, but they're able to still bill for that. So what I found is if hospitals or those able to bill, who would be physicians or radiologists, are in that mindset, they'll find ways to continue to bill for a procedure, even though the efficiencies are being improved. We've had some radiologists just want to wipe their hands clean completely of PIC insertion because it's like a never-ending thing that they have to do, that actually they can bill for more complex procedures.
I
So
see. Yeah.
it's kind of, it depends on the individuals, but I hear you. And overall, I mean, do we have an opportunity to allow other professionals to bill for procedures? I mean, that's a huge question. Right now, it's not possible, but do we have other, I'm thinking nurses, I'm thinking rad techs, I'm thinking,
Right.
Anyways, it's a great question.
Thank you.
Yeah.
Any more questions for anyone else? Otherwise, Jeff, please keep going.
Keep going, Jeff.
I can keep going. Yeah, so I really liked the video of the nurse giving that TED talk. It was inspiring, I think, that companies still in this day might approach medical product development as a group of engineers. I'm going to paraphrase, not her actually, but in their garage dreaming up a solution and not talk to the end users before they design something and then give it to the ER or wherever it's supposed to go. And it's an issue of education, I think, because right now there's design control is a required element of FDA product development and for ISO 1345. Yet people are trying to get shortcuts instead of doing what the user needs step, which would be engaging in the nurses to find those technology gaps that they need to fill and then circulating back to the nurses as they're developing their product to get essentially their first version, something very close to what they want rather than their fourth or fifth, or the company fails because they basically didn't produce anything anyone wanted. So I'm trying to circulate to a question, but our program here, the MedTech program, is attempting to try to encourage education in young entrepreneurs to that process, the design control process, so that they understand that getting the user needs is important at the beginning. And I think that's different because before, I've been at this for a while, students would graduate without much training in that. They'd become an engineer in mechanical or industrial or something like that, and become a medical device developer. And so the training at the medical device company would take years to instill in them proper design development. And do you think, I guess, finally getting to the question, this needs to be enhanced in the academic environment? In other words, the ivory tower needs to teach them to be a bit more ready to do what companies actually need to be successful, even though it might not be progressing them towards a thesis.
Well, I think legally it has to be done. I think we have a lot of idea people, which we need, but we also need process people that can bridge those ideas in the way that is legal for FDA standards. And when you're talking health products and practices, you're talking about life and death. So I think it's a non-negotiable that obviously those processes have to be followed. So maybe having exposure to those early and more frequently in education for engineers would help normalize that. I don't know how much exposure they have to that now, so I'm not informed in that way.
Right. Well, this program is trying to introduce that, but it's coming. This is a bit of philosophical, but the standard way of teaching is the professor teaches the theory and gets them to practice the problem sets, and they come out knowing how to engineer, how to design, and maybe even develop ideas. But how to do that in a regulatory environment is being addressed increasingly in engineering. But we still get the feedback from companies that it still takes a long time to train them to understand the particular regulatory process that particular company needs to follow. In other words, they do not know the ISO or FDA process when they come out of school. They have to learn it, and they learn a piece of it because their role is one design element or something like that. And it disappears into knowing what the entire process actually is. Whereas I have a feeling that the process needs more attention in biomedical engineering in particular.
Mm-hmm. Yeah, I'm just thinking of nursing education and how we can learn the theory of how to place an IV, but we come into practice without maybe actually having done one in a clinical rotation. And then the hospital,
so it's similar,
similar. So I think, and taking it from a nursing lens, we really need to work on it is the art and science of engineering and the art and science of nursing. So in addition to the ideas, I think the science is that process that has to be followed, and maybe collaborating with MedTech companies to help bring a real life application of using that process to help students understand how meaningful it is, but having it from the lens of this is actually what's happening in the real world instead of just theoretical. You could bridge that with how they're doing that in the MedTech industry. Mm-hmm.
Yeah, thank you. I'm sure Jesse could comment tons on what our program tries to do in those respects. But I've monopolized the time, so I think thank you very much.
Thank you both for that great conversation. I'll just mention that a hackathon was mentioned in your presentation, and we just completed a hackathon, an annual event that we hold every year for the MedTech Talent Accelerator. And that was for optimizing the flow of emergency departments. And we involved many clinicians, but regrettably not as many nurses as we should have. And one of our clinicians said that he would argue that an ED can run without physicians, but not without nurses. So we definitely should and will strongly consider bringing in nurses for our next hackathon.
Yeah, I would highly encourage, and there's a paper that was written, I read, talking about a conductorless orchestra So in an emergency department, you've got all of the workers working together, really could do it without even a manager, because everybody knows their role in that functionality. And it's talking about the transitions in leadership and people coming and going so quickly in healthcare. So, but the worker bees, those doing the work, it's like a dance they do, right? And you probably saw that when you were working on ER workflows, that people know what their roles and responsibilities are. But how can we make that better? Great.
100%. Okay, so we're at the top of our hour here. So I want everyone to please join me in a virtual round of applause for Sarah. Thank you so much for your excellent presentation.